Hi everybody, it's Dr. Peters and I'm going to talk about cardiac diagnostics, what to order and when to order it. So what are some reasons for stress testing? So I'm going to talk about stress testing, but then I'll also get into when you would order a complete echocardiogram, what's the difference between that and a stress echo, and then some other diagnostic imaging that we really wouldn't order in primary care, maybe a couple things, but that would be more reserved for cardiology. But let's start with the stress test. Why do we do that? People that are at high risk have risk factors, early family history, diabetes, obesity, if they smoke, hypertension, hyperlipidemia. So those are high risk factors that, and if they're having any symptoms, you get a stress test. And we're checking for any obstruction in any arteries. So that's what we're going to talk about today. Also, people that have had heart disease, that have stress or stents in, or they've had bypass surgery before, they should have a yearly stress test just to make sure that everything's clear and they're still having good function of their heart. So these are the types of tests. We have a routine exercise test on the treadmill. Then we have a routine exercise with an echocardiogram or ultrasound of the heart, but it's not a complete echocardiogram, it's a partial echo. So they're basically just getting images before exercise and after exercise when your heart is still at 85% of your maximum heart rate. Then we have pharmacological stress tests, and those are for people that really can't walk on a treadmill. So you're still doing really the partial echocardiogram before and after, but instead of on the treadmill, they're actually being injected with medication to bring their heart rate up to where it should be. Then we have imaging studies. When I think of that, I think of it's added to the stress test. So it's nuclear med, and it takes pictures in addition to the echocardiogram and walking on the treadmill or exercise. So what you would do is you would pick a nuclear med pharmacological stress test, and you would add, the imaging study would be added in to the pharmacological part to it, or the routine. So you can pick either one of these, and then you can add nuclear med to it. Every hospital system has different ways of ordering, so that would just depend on your hospital. Also, hospitals have different medications that they give to bring the heart rate up. So while I'm used to LexiScan stress tests, some people may not have heard of that before. I'm sure most people have heard of dobutamine stress testing. So quickly about routine exercise testing, it's not ordered as much anymore. It's not, the sensitivity and specificity isn't as good as some of the other ones, and we routinely would just order the partial echocardiogram with it, but this gives you a good idea of what you do. You have your heart rate monitor on, you have a blood pressure cuff on, and you're going on the treadmill and you're bringing your heart rate up. Use a certain calculation to determine what your maximum heart rate should be, and it should be at least 85% of that. And so this is checking to see if your blood pressure changes drastically. It's obviously going to go up when you're exercising. That's normal, but we want to make sure it's not going too high. And it's also checking for any arrhythmias or to see if you have any chest pain. So that's simply what it is, going on the treadmill and you're hooked up. But when we do stress echocardiography, that is, you're still going on the treadmill with the same hookup, but we're doing a partial ultrasound of the heart. So you're laying down, they're doing pictures of your heart to check the function. You get on that treadmill and you get your heart rate up, and you immediately lay back down on a table and they take pictures of your heart function again. So this will check to see how is your heart pumping while it's being stressed out, while it's being stressed. Is the motion of the ventricles and the atrium moving that the way they should? Is it the same as at rest as in exercise? So usually a cardiologist will do that, or I have been seeing that other technicians will be doing those, and the cardiologist will read it afterwards or call the cardiology in if it's abnormal. And it's very time sensitive, because remember that heart rate, if you have a quick recovery time, if you're in shape, it can go down pretty quickly. So remember, it's not a complete echo. So if you want to get a full echocardiogram with them checking every single part of blood flow in your every valve and checking all the valves, That's not what you want to do. You want to get a complete echocardiogram. If you want to stress the heart out with pictures, then you want to get the stress echocardiogram. And we'll talk about when to get what towards the end. Now let's go into pharmacological testing. So again, think of the same thing as before, except you're not on the treadmill. You're still getting pictures of your heart, but you're also adding medication to raise your heart rate, because these people cannot go on the treadmill. And there's a lot of people that are wheelchair bound, have arthritis, or the type of surgery they're having, etc. So one thing is dobutamine. So anybody with COPD can have dobutamine, and basically any other like Lexiscan is contraindicated for dobutamine or for COPD patients. So when you see a COPD patient, just think dobutamine stress test if they cannot walk on the treadmill. And so I'm not going to read through all these slides because I know you guys can read, so that's why I basically will just kind of do an overview of those. And nuclear imaging test. Nuclear imaging, you do the exercise part, so whether you're going to inject the medication to bring the heart rate up or you're just going to go on the treadmill to bring your heart rate up, this is an added portion to it. It does radionuclide images at rest and at exercise, so you're still getting your heart rate up, but they need to get to nuclear med, which is usually right near there because they do this kind of testing. But remember, your heart rate can go down, so they need to walk 1 more minute. So you don't just stop right when it gets to 85. You want to keep that heart rate going so they can get to the imaging place and they can get accurate pictures. And this is just another added picture that can determine whether they have any what they call perfusion defects. So is it perfusing well, and you can tell by the pictures if it is. If it's stable, unstable. Some people who have had heart disease, it'll show that they have a fixed perfusion defect in this area of the heart. And we just know that they have heart disease and they've already had an MI in the past, so they're going to have that. But in a lot of cases, it's abnormal, and so we have to make sure, and so we send them to cardiology. There's also some people that are morbidly obese. The pictures might show up a little abnormal. So if they read it, it will usually say this could be too large body habitus or increased attenuation from maybe the way the patient was breathing, etc. So it has a really good negative predictive value. So that means that if it's negative, then we can be pretty sure that it's negative. If it's positive, that's your positive predictive sensitivity. It's not always positive. You have to sometimes get that checked by the cardiologist, but usually if it's negative, it's negative. And it costs less. It says it costs less than a cath, meaning cardiac catheterization, which I'll go into in a little bit here. So here's just some differences between just getting the stress echo and then adding the imaging. So the stress echo does have a higher specificity, more clinical information, greater availability. It doesn't have radiation, it's cheaper. Not saying that it's cheap, but it's cheaper. Then when you add the perfusion imaging, we know it's going to be more expensive and you bring in some radiation. But it's really good for people that have had a past history of heart disease. It's really good for people that have a lot of risk factors to add that perfusion imaging. There is a higher success rate. Also, it has a higher sensitivity and not specificity. So sensitivity is really important, particularly the left circumflex artery. So the anterior wall of the heart, it's really good at picking out abnormalities there. So there's better accuracy in evaluating if there's any ischemia or blockages in the setting of resting abnormalities. But it doesn't mean you have to order it on everybody, and we'll talk about that. So interpretation issues. So there are always interpretation issues. Sometimes these are subjective. Sometimes T-waves changes are common. That's normal. Some people may have had ischemia and MI, and now they have the T-wave changes, but you can still have the T-wave changes and it'd be a normal finding for that patient, and they haven't had an MI in the past. Assessing for a wall motion abnormality and stress compared to rest. The echo, the nuclear med issues, or the nuclear med will be more specific on that. They have a higher sensitivity than specificity, and sometimes the echocardiogram, you can't always detect wall motion abnormality when you're comparing the two. Inferior lead changes, there's a higher false positive rates in women, and test graded positive or negative based on ST segment changes. So that just means that sometimes you have to follow up with cardiology to say, okay, is this a positive test or is this a negative test? The important points are, if you don't need to give a medication to bring the heart rate up, then don't use it. If they're willing to walk or willing to try, it's always good to have them try. I've had patients come back to me and say how awful they felt with the medications they give them, and I couldn't imagine getting the medication either to bring my heart rate up that fast just sitting there. It's probably an odd feeling. You also need to be able to lie down for 20 minutes 2 times. You need to be pretty quick. And some places where you order them, you can start with the stress walking and then they will change it automatically based on their own protocol, but not everybody is like that. So they may have to call you and say, hey, can we switch it to a pharmacological stress test? So exercise testing is the most valuable when pretest probability is intermediate. We're going to talk about pretest probability. To assess the pretest probability, you need age, gender, and symptoms. This can help you determine what kind of or what test to order, or if you should order a stress test in general. I know this is blurry, I'm very sorry, and I cannot find this for the life of me. So if you want to recreate the table and share it, go ahead. But this is a really good table to determine if they need a stress test. So let's just say someone is 35 years old and they don't have any symptoms at all. And because you're looking at symptoms here, and then you're looking at the age. So very low, as we go back here, pretest probability that it's going to be abnormal. So it'd be a very low chance of this patient having a positive stress test. But if you get up here and say this patient is having chest pain at rest and with some dyspnea and having that typical chest wall pressure, jaw pain, arm pain, then it becomes more intermediate to high, especially as you get older here. As you can see, especially, and women, sometimes I think this women should be changed to high, although I didn't know what the research said to make it intermediate, but we have to remember women present a lot different. So this can help just a little bit. It's not a in pen written guideline, but it will help you. You have to tailor things to the patient. And what determines if it's atypical or typical? Sometimes you don't know that when you're talking to the patient. So what's the difference? Typical versus atypical. Typical angina is usually people that have already had heart disease and they have just like a minor blockage, or they've had a cath before, and let's say they have 40% blockage and it doesn't need to be stented, and they're on medications, and they start exercising. What happens? You vasoconstrict. So then that person that has the 40% blockage, you might be blocking off some of the blood flow going through there. So now you're going to have some pain. And so then you rest, lay down. Does it go away? Once things calm down, your blood pressure goes down, your vessels dilate, or do you need nitroglycerin? Does it go away? That's typical angina. Atypical angina is not normal. That is if you have 2 out of 3 of these characteristics. Okay, usually people that don't typically already have heart disease and they have some blockages, or people with typical angina can have atypical angina, and that could mean something could be completely blocked off. So again, you have to go by what the patient's telling you. I play it safe and sorry. I don't even mess around with looking at these. If my patient's telling me that they have chest pain or dyspnea on exertion or at rest, I'm saying or, jaw pain, arm pain, some strange shoulder blade pain, I would rather play it safe than sorry. I don't mess around. If they're having active pain, they go to the emergency room. If it was 2 weeks ago, then I would order a stress test or do an EKG in the office. And remember, sometimes this can be GI related, but I always say you can't live without your heart. So you always have to exclude the heart stuff first before you say that it's anything else, musculoskeletal or GI, because all of these nerves in your chest wall area, you have a bundles of them, and so you can have a lot of referred pain. That's why women present so differently too. It doesn't necessarily have to be the pain right here or pressure right here. Women present with nausea, and sometimes you just don't know. So it's better to play it safe than sorry. So what about women? I mentioned all these before. Women are more likely to have one vessel than men. Women are more likely to have microvascular disease, those little tiny vessels that come off from the main vessels. But again, you have to be careful with females. There's a lot of research being done on females now, which is good. Here's your sensitivity and specificity, which obviously as we add medication and do nuclear imaging, it becomes a little bit higher. And I don't have the cardiac catheterization on here because that would be pretty much higher, because we're going directly and taking a look. I don't see PET scan orders, so that was just on the table here. Appropriate use criteria, I'm not going to read all of this, but it's basically saying that you have to order things reasonably and you have to weigh the risk versus the benefits. Like I said, I'm usually one that doesn't play around with patients, but if you had a normal stress test 2 years ago and you have no changes in your EKG, there's no reason to order another stress test. Even 3 years ago, if the EKG's not changed and they have not had any symptoms, there's no reason to get another stress test. So just keep that in mind. One thing is that you're always going to be comparing EKGs to past EKGs. It's really smart to get a baseline, because when they come in again, you can say, I need a copy of the last one. And then you look for changes. That helps guide me to whether I'm going to order another stress test or not, if there's been a change. And some people have subtle changes. It says, if they have anything going on. So radiation exposure. We know about radiation exposure. And it is a lot of radiation, cardiac cath, as well as the nuclear med. So just try to understand the difference that we do have radiation versus non-radiation. So there are a lot of people that just can do stress echoes, meaning on the treadmill with the partial echo. Here's a management strategy. Again, I don't know where I got this from, but I found it and it was good. And I can assure you it was from a reputable source. I never would copy anything from a non-reputable source. So we have the Framingham risk scoring. There's also now the AHA cardiovascular disease risk calculator that can help determine what risk factors patients have. But if you want to, again, somehow print out this slide and keep it with you, this is another way to kind of help you determine whether they should be going for a stress test, or if you need imaging with it, or if they should go straight for a cath. If someone has all of these symptoms above, and this is another good thing to bring up, markers. Okay, if you're in primary care and feeling like you need to draw troponin, the patient should not be in your office. They should be going to the ER. So, because why would you draw troponin? Because you're checking for any heart damage that's happened immediately or within the last 72 hours or so. So that means that they shouldn't be in your office, that's more of an emergent situation. Okay, so just give you an idea of that. Cardiac cath is always the gold standard to go in and take a look to see if they have any blockages. Depending on where the blockage is and the amount of blockage they have going on, over 50%, they usually will put in a stent. They're drug-eluting stents. That's usually the gold standard now too for what kind of stents they put in. They put those in, they need to be on antiplatelet therapy and anticoagulation therapy for at least a year. So we'll have people on Plavix and aspirin for a year. But it depends again on the type of drug-eluting stent that goes in. Some require 3 months, some require 6 months. I work in a pre-op area. I won't let anyone go to surgery unless it's emergent. If they've had a drug-eluting stent within the last 6 months, and I make sure that they always see cardiology. But some cardiologists want them to wait a year. especially if it's elective surgery. Now here's the complete cardiac echocardiography, and these are for people that are having like heart palpitations, atrial fibrillation, or if you see something abnormal on an EKG, such as a left atrial enlargement that can show up as a recording. What that tells me in lead 2, especially lead 2, is the P wave notched? Is it wider? I have a little, measurement thing that I use. If it is, then that tells me, if there's something going on with one of the valves. So that would guide me to order this. If someone's having like some weird chest pain or having other issues, which I will get to that slide, then I wouldn't order the complete echocardiography. I would order a stress test. But this is checking like anybody that has heart failure. If you have an enlarged heart that you find on an x-ray, again, I said the atrial fib, anything like that, you want to get a echocardiogram to find out what is your heart function doing, what do your valves look like. If you hear a murmur, order an echocardiogram, not a stress test. Okay, if you hear anything weird on heart tones, you would be getting an echocardiogram. And how do you interpret the report? Well, the report should be written out pretty well, but sometimes they're not. But I know you guys already went over heart failure. So if you have diastolic dysfunction, it could usually your ejection fraction's preserved because the diastolic dysfunction means when your heart's at rest, so it's more stiffening of the ventricle. So you may not see any abnormalities in that, but it'll show you have diastolic dysfunction. If you have systolic dysfunction, you may have a low ejection fraction. So again, with heart failure, I'm not going to go into that, but it's a grading system, that kind of stuff. So, okay. It checks for valve function. Now there's a coronary CT where you can just look at the coronary arteries. I've never ordered one. Cardiology may order one, but it checks for plaque and calcium. It's completed in less than a minute. And this is probably the calcium scoring now that I'm reading this. There's two different ones, and I think this is just a regular coronary CT, which is the angiogram. Actually, that's what this is. It's the angiogram that puts the dye in. So usually people go straight for cardiac caths instead of doing the angiogram, but again, that's cardiology would be doing that. And who should not have a coronary angiogram? If you think that there's really a strong probability that they have narrowing or a positive stress test, you're just going to get a cardiac cath. Okay? Then there's MRIs, which cardiology would order. I've never needed to order that, but if someone has a mass or something that's been found, you would order the echocardiogram. Say they found something on a chest x-ray, you get the echocardiogram, but then you'd refer to cardiology and they would get the cardiac MRI. This is the calcium scoring that these people, anybody, the population can go for, calcium risk scoring. It just checks calcium deposits. It doesn't always check every type of plaque that's built up in there, but it is actually more and more people are getting it. So these are some risk factors that will determine, well, maybe I'll get one. And what they do is give you a score. So if you have no calcium, you have a score of 0. And so it's one of these things, you get it, now what are you going to do with it? Like if I went and got one and my calcium score was high, I'd probably freak out. So then I'd be going to cardiology and stuff like that. So when do you consult? So you consult chest discomfort. If they're having chest pain, you always do an EKG in the office. If they're having chest pain right then and there, they go to the ER. If their stress test comes back abnormal, they will go to cardiology. I'm just giving you like how I am in the office, what should be done when you're in primary care. Anytime someone has a syncopal episode, you want to think cardiac, so you put them on a Holter monitor. Doesn't mean you send them to cardiology right away, but get the monitor first. If there's any abnormalities, they need to see cardiology, because what if they're having runs of VTAC? Okay. Let's see, heart failure difficult to manage. A lot of places, unless you work rural, have heart failure clinics. If you work rural, you'll have to manage the heart failure. So, and we can definitely as NPs manage heart failure. Our heart failure clinics are managed by NPs. New atrial fib. I always refer to cardiology for AFib. Well, I work in a pre-op clinic, so they do go there. But I will order, obviously we would find it on listening to the patient, EKG. I'd send them for an echocardiogram, and I'd get them over to cardiology. They're used to getting up there the same day. And then work up shortness of breath before consulting cardiology. It's just some pearls. You want to make sure you check their symptoms before you're consulting. You can consider their probability of coronary artery disease. Think about the radiation. Remember, an echo is easy, cheap, non-invasive, no radiation. Sometimes body habitus is an issue, but that's an issue even if you're doing nuclear med. For advanced cardiac testing consult, well, that means like, why would you get an MRI? And I just don't think that you guys would do that anyways. You would consult, but that's what stress testing is for, unless they need in cardiology to look at things. So this is very helpful to me because I look at EKGs every single day. I have these memorized, but it's a really good thing to print out or make a chart or something, because if you're looking at an EKG, what part of the heart am I looking at? And sometimes, or many times, your EKG will read septal wall infarct or inferior wall MI. And you're like, okay, is this really an inferior wall MI? Is this not? So first of all, I have a tool that I use that, and you can just use a piece of paper just to look to see if they have any ST elevation or depression in any of these leads. So if it says anterior wall MI and it's reading it out, remember, you don't go by what the machine says. You got to read it first. I never look at the top part of it until I've read the EKG. So you have another one to compare it to. Are there any changes? Okay, that would be consideration for ordering a stress test. Number two, look at these. If it says anterior wall MI, I'm going to look at V3 and V4, and I'm going to say, hey, is this a true ST elevation or not? I'll take my handy dandy thing. You can even buy them on Amazon. They have like really cool EKG. It's clear with a line, and you can put it over to see if there's elevation. Or lateral wall, and try to understand where that is. So this is another good thing, and I put the link here so you can actually go to that site and take a look and just read it. It's actually pretty good, and I love this chart here because it'll tell you, okay, if it's reading out as a septal infarct, you're going to be looking at these leads to see if there's any abnormalities. Of course, you always look at all of them. This would be determination whether they are going to the ER. If it's definitely an MI, that's not good. So you'd have like significant ST elevation or depression depending which way the leads are. Or it would determine whether you are getting a stress test, okay? Or it will determine whether you need an echocardiogram. So for example, I see left atrial enlargement a lot. So I'll see that more in lead 2 over here, and will be like wider, and you'll have a notch there. And if it is, I order an echo. But if I see any abnormalities in any of these lateral leads here, anterior leads over here, I'll order a stress test. If somebody has left ventricular hypertrophy, that tells me, do they have a heart failure going on? Do they have long-standing hypertension? I'll probably order an echocardiogram, like a complete echocardiogram, and not a stress test. Okay, so when you're looking at PQRST, like ST elevations or anything weird, then that's when I'm ordering stress tests. So I hope that helps. You can click on this, but I do recommend ordering a tool that you can use for, it's like just a quick tool. I don't have it with me, but you can just Google it on Amazon, EKG reading tool, and it'll come up. So, all right, and if you have any questions, you can email me anytime. Just ask Dr. Parvey for my email address, and it was a pleasure, and take care.